Today I would like to share with you my technique for dealing with intumescent cataracts. As we all know, with this type of cataract there is a high tendency for the anterior capsule to extend radially due to the high intralenticular pressure, giving the classic Argentinian flag sign. After staining of the anterior capsule with trypan blue dye, generous amounts of viscoelastic is inserted into the anterior chamber to raise its pressure. I use a 27G needle attached to a 3 ml syringe with the bevel down to pierce the anterior capsule exactly in the center and aspirate as much as possible of the liquefied cortex. I repeat the step 2 or 3 times to make sure that I have aspirated all the liquefied cortex that can be aspirated from within the bag. I tend to perform the needle aspiration through a 1.2 mm wound. At this point of surgery I have not yet created my main wound. Repeated and generous injection of dispersive viscoelastic keeps the anterior chamber pressure equal to or even higher than the intralenticular pressure, thus reducing the risk of anterior capsule extension. Even though the previous step brings down the intralenticular pressure markedly, I still tend to do a mini rhexis and try to aspirate more of the cortex with a double-way cannula. At this point I can safely enlarge my main wound and access it with a double-way cannula. The wide bore of the double-way cannula allows aspiration of more of the liquefied cortex, giving way for any trapped fluid behind the nucleus to be aspirated. At this point, the pressure inside the bag has decreased markedly and it's safe to enlarge the rhexis. I use a pair of micro scissors to create a snip in the anterior capsule and the capsular rhexis forceps to enlarge my capsular rhexis. Although the nucleus is quite dense, yet it's small in size due to the amount of liquefied cortex that was present, and usually a 4.5 mm rhexis is sufficient to carry out the rest of the surgery. The rest of the surgery is pretty straightforward: phacoemulsification of the nucleus and implantation of an intraocular lens, but I would like to state a few key points when dealing with intumescent cataracts. First of all, always take time to plan your surgery ahead. Taking the time to plan the surgery will save you time later during the surgery itself. Secondly, when dealing with intumescent cataracts, always keep your anterior chamber formed. Always keep the anterior chamber pressure higher than the intralenticular pressure to avoid extension of the capsule. When you use the needle to aspirate the liquefied cortex, always keep the bevel down, always attack the capsule in the center, and give it one controlled pierce without hesitation. If you are going to use the needle to repeatedly aspirate the liquefied cortex, try to keep it in the center every time, Don't move it sideways, as the side of the bevel of the needle itself may actually cut the capsule. A double rhexis technique and aspiration using a double-way cannula may save you from any surprises due to trapped fluid behind the nucleus. Finally, I hope this video has been quite beneficial. Please take the time to share your own experiences when dealing with intumescent cataracts. Thank you very much for watching.